Emergency medicine is more than just ordered chaos.
From the recess room to the bedside, we are witness to it all.
And we're here to help you prepare for it.
Bringing you the brightest minds in emergency medicine from around the world for trusted, tried, and true free open access medical education.
I'm Dr. Anton Hellman.
And I'm Dr. Katie Lynn.
Katie, let's welcome the listeners from our amazing EM community to the Emergency Medicine Cases podcast, shall we?
Yeah, or let's simply call it EM Cases.
Okay, EM Cases.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases. ED visits for pediatric mental health and behavioral emergencies have surged over the last decade, and we're seeing more and more agitated children and teenagers in our practices. But many hospitals lack pediatric-specific guides, policies, and procedures to help us manage this population well. And the management of these patients is not so simple. It depends on the severity of the agitation, the etiology of the agitation, the underlying stressor, and the resources that you have at hand. A poorly managed agitated child can be detrimental not only to the child, but to you, your team, and can even disrupt the entire emergency department. So to help us sharpen our management of these sometimes challenging patients, we have two new guest experts to EM Cases, Dr. Susan Duffy and Dr. Tom Chun from Brown University in Providence, Rhode Island. They wrote the CHECK guidelines on the management of the pediatric agitated patient. Welcome to EM Cases, Dr. Duffy and Dr. Chun.
Thank you.
Thanks for having us.
Can you tell our listeners a little bit about your professional lives and how you got interested and knowledgeable about pediatric agitation in the first place? We'll start with you, Dr. Duffy.
Thanks, Anton. I'm a pediatric emergency medicine doctor, so trained in pediatrics with a fellowship in emergency medicine. And I have practiced at Brown at Hasbro Children's Hospital, which is the tertiary care hospital for all of Rhode Island, for over 25 years. It was during my time as the medical director of the Hasbro Emergency Department that there was starting to be a true escalation in children with mental health problems who presented to the emergency department, both in crisis, as you always present to emergency departments, and then for access to care. We didn't have systems or processes in place. There was really fragmentation of who evaluated them. As we all know, as emergency physicians, there's very little training in mental health, and it really wasn't what I think most people thought of as in the scope of their population. So I started to work collaboratively with our psychiatry team to embed mental health resources and develop processes. Subsequently, as we all know, more and more children are presenting for care, and so there really became true quality issues in our emergency departments and a need for us to adapt our systems to approach. And so I, along with Tom, became part of a group of people who started to work on this. And we were, I think one of the first instrumental factors was HRSA put together a group and we developed something called Critical Crossroads, which is really the first toolkit to look at systems issues and processes for caring for kids who have mental health problems. And agitation is one of the most critical safety and disrupting events in emergency departments. I think if you ask most emergency physicians, what is your least favorite type of patient to care for? It really is the agitated, undifferentiated patient. You'd rather take care of a stroke or a septic patient because there's processes in place. So that's really how I got into it and have been involved with the American Academy of Pediatrics, EMSC, and fellow colleagues. And it's really become a true change in adaptation to emergency medicine.
Wow, good for you for stepping up and doing all that important work to really make a difference. That's fantastic. And Dr. Chun?
So, as you heard, Dr. Duffy, who is my partner in crime, and so really so much of what she said is paralleled for me. My interest started that I entered pediatric emergency medicine through an atypical route. I came to Brown to do a combined residency in pediatrics and adult psychiatry and child psychiatry. So that's where my mental health interest came from. And my professional career largely mirrors what Sue just described. How to bring together psychiatry and pediatric emergency medicine is really one of my great passions.
Fantastic. I want to start our conversation with the recognition and categorization of the agitated child. The first step in managing these patients is kind of sorting them into 3 categories of agitation: mild, moderate, and severe. Now, in our adult agitated patient episode, we explained that mild agitation is essentially agitated but cooperative, moderate is disruptive but without danger, and severe is dangerous to self or others. But kids aren't just little adults, as we all know. Dr. Chun, how do you assess at the bedside what category the patient in front of you fits into?
So I do like the categories because I think kids are similar to that. I would say 2 things immediately come to mind. First is aggression is a symptom, and the key is, as best you can, to rapidly assess for the underlying cause and determine what the safety risk is, because that's really drives what you do next. And the safety of the patient and the staff is the number one driving consideration. Some of it, you could say you know it when you see it. There's an obvious visual difference between mild or moderate or severe and how risky a patient is to themselves. There are some rating scales that have been looked at, including studied in kids. One is the ABRAT, which is the Aggression Behavioral Risk Assessment Tool. The other is the BRCA, which is the Brief Rating of Aggression by Children and Adolescents. That's been used in inpatient settings. So there are tools out there to help you assess. I would, in some though, say it's really about safety and what do you feel as a treating clinician is the risk of danger to the patient and to themselves.
All right, and Dr. Duffy, anything to add in terms of the categorization of the pediatric agitated patient?
I think it's important to really define the level of agitation, because defining the level of agitation determines how you're going to respond, where you're going to place your patient, what level of observation they need, what kind of testing that you're going to do. So it's really a combination of the beginning of a diagnosis, but it's also a safety issues. So it's important for multiple reasons: for safety of the other patients, for the safety of this patient, and then figuring out like what are the next steps. So I do think for emergency physicians to sort of categorize patients and teams, because this is definitely takes a village to take care of patients who are agitated, and the team all accepting that this is a level of agitation is important.
So, again, our first step is to categorize the patient into mild, moderate, and severe. And that's a little bit about how to do that and why it's important. We want to think about how we can prevent agitation and escalation of agitation in the first place. Ideally, we want to identify these kids who could potentially become agitated before they become agitated. Dr. Duffy, are there any ways that we can predict which pediatric patients are going to become agitated in the ED and prevent that agitation?
Yeah, I think the word that how you started the conversation, Anton, is really important. Anticipating the agitation is probably the best thing we can do, and identify those who are at risk. And that really starts at triage. So anticipating agitation at triage is a very, very important factor. Adapting your environment immediately by anticipating agitation and the potential for agitation. And also, we all should be using a trauma-informed approach, I think, when we take care of everyone. And by trauma-informed approach is someone's past experience definitely impacts how they respond to an environment. And this is particularly true for this group of patients. Many children who have agitation and have mental health complaints have had previous trauma, and how they're reacting to their environment is important to anticipate so that we can create environments that really mitigate any kind of effect from being agitated. But there are some sort of past history factors that are important. It includes, probably most important, a prior history of aggression. That's the most predictive factor. And the reason, if the visit is associated because there was aggression, even though the patient isn't aggressive in front of us, knowing that that was the key to the reason that someone came by police or ambulance or by parents, nobody wants to come to an emergency department. So even if you have a calm patient before you, knowing that is important. There's some factors, and adolescents are at increased risk for agitation in general. I think it's just the time of life. Males have been in studies, have had increased risk of agitation. Having a mental or behavioral health in that complaint or past medical history increases the risk. Substance use, either current substance use or a history of substance use disorder. And then having a neurodevelopmental disorder such as autism spectrum disorder or developmental delay, and having difficulties with sensory and communication issue, processing issues, means that the way that a patient might react to their physical environment and a kid interact makes an increased risk for aggression because they have difficulty communicating their needs. Kids who have histories of trauma and abuse and neglect also have past history. It's the way that they've learned to communicate and process their environment as well. So really, I can't overemphasize enough that our reaction right from the start and how you set up the environment for a patient, anticipating that they may become agitated, really can change the whole course of the visit.
Yeah, let's dig into that a little bit more. So, what would you do if you, say, had a teenager who you find out very early in the history that they have a history of aggression, that maybe they had a history of abuse? They've got all the risk factors, let's say, for becoming aggressive in the emergency department. What would you do? Again, this is in the preventing agitation. If you could just give us a sense of a few of the moves that you would make to prevent the agitation in the first place.
Right away, I would adapt the environment and all of our team's approach to how we interact with the patient. So first of all, I would not have them wait in a crowded area. I would make sure that the patient is in as calm as possible environment. I would ask them what we can do to make the visit more bearable, comfortable. Who do they want around with them? Would they prefer a parent or not a parent? Is there something that we can do, offer calming things like food but just from the start, let them have their space. I think having your space is really, really important. Checking in general, sort of a non-confrontational manner with the patient. I think this is true in adolescents in general, and how they react to adults. Just being sort of even keeled, non-judgmental, asking them what you can do to make this as bearable a visit, even though they may not want to be there. Oftentimes, when somebody's got a behavior or mental health issue, we are doing certain procedures to keep them safe, and that involves asking them maybe to change their clothes, asking them to give us their cell phones, which is a hot button issue with them. Then, as you're doing that kind of approach, it's really negotiating with the patient so that you set limits, but still allow them that they have some control over what's going on in their environment.
Fantastic. I mean, these are really just very simple things we can do just to prevent the agitation in the first place, which really can save us a whole lot of time and anxiety for the patient, for yourself, and for the team. So I love that. Keep it simple, just a few small things. Dr. Chun, anything to add there in terms of preventing agitation?
Yeah, I completely agree with Sue. And I find that direct communication But very importantly, as Sue said, not confrontational, not threatening, really trying to understand. Ask them direct questions. If they've had previous experiences, what worked, what didn't work. Gives you a real idea of what might cause problems, what helped. Being real clear about what the goals are, what the expectations are of them and of us, that you want to keep them safe. You want to help them. Ask them, how can we all be safe? Seeing what they say and really hearing them out. To Sue's point, ask them, what people do they want? What people do they don't want? Sometimes it's as simple as that. Removing someone's actually triggering. And once you remove the trigger, they're actually a lot better. So it's really understanding the patient and asking the patient. And often there's a parent or a caregiver there. What works, what doesn't work. It's as simple as that.
If I could just add also something I've learned over the years, don't ignore this patient. And I think in emergency departments, because they are there for a long time, kids with mental health problems, it's a long process often. And if they feel ignored, it escalates agitation. So it doesn't necessarily have to be the physician, but the team of people, the nurses, the constant observer, just touch points along the way so that they feel like somebody's paying attention to them.
Yeah, I mean, most of our emergency departments have pretty long wait times, and the potentially agitated child, you really don't want to have wait for any longer than they have been waiting, because just seeing them in a reasonable amount of time could prevent the agitation in the first place. So that's something to think about. Of course, we have to prioritize very sick patients, but this patient who may not appear to be very sick from the triage note, when you're deciding who to pick up first, could very well become very agitated and then again disrupt your entire emergency department. So it might be worth putting them a bit higher on your priority list to see sooner. All right, we've covered categorizing your patient and we've covered preventing the agitation, but we don't always recognize that we can prevent the agitation, and sometimes the agitation just happens. Dr. Duffy, could you give us an overview of the initial stabilization and management of the agitated patient once we've decided that they're mild, moderate, or severe in their category of agitation?
Yeah, and I hate to jump to a categorization again, but I think that once again, we're in an emergency department. This all starts at triage. Having protocols in place and thinking about how you're triaging a patient, a behavioral health, mental health patient is really, really important, and how we follow through with stabilization and initial management. Australian and Canadian triage tools are a behavioral health triage assessment tools that I think are moving to most emergency departments are adopting some form of that to how they initially manage patients with mental health problems who walk in their doors. And it's really looking at, is this patient a severely agitated patient, and is this a level 1 kind of patient? If you think about it in our ESI categories a little bit and those terms, so who needs to be there? There needs to be a physician assessment as well as a safety team who's involved in their care. Then there's those emergent patients who are our level 2s, who are probably a danger to themselves or others, and they need involvement of the team, which includes medical team. And then you move to your urgent patients who are probably a danger or possibly a danger to themselves or others. And their issue is initially safety, and then medical stabilization comes after that. And then there's the less urgent patients. And then you have to determine your initial management is, what's the safest place for this patient? And some emergency departments use their critical care rooms for the severely agitated patient. To me, that's probably not the safest place, but just to have a system in your department. Other places use a calm and collective place, but this is an undifferentiated patient often. So you're going to have to do a medical assessment as well as a mental health assessment and intervention at the same time. So you have to decide that location. That classification determines your location. It determines your level of involvement of security and other people in your team. And then at the same time, you have to do this brief medical assessment. and say, can I differentiate this patient and assess these red flags that say this is more likely a medical etiology? And I think that's why emergency departments do choose their critical care room, because that's where you can say, is this delirium? Is this a head trauma or some other kind of trauma? Is this a metabolic problem? Should I be doing, does the patient have DKA or hypoglycemia? Are they hypoxic? Is this a drug effect? If this is a drug effect, then they probably belong in your critical care room. Is it an infection? Is it in withdrawal or intoxication? And so you use that to really do your initial assessment. And then at the same time, where we're doing this initial medical and safety assessment, we're also thinking about initiating de-escalation techniques. And that really has to start the moment the patient walks in the door. De-escalation and verbal de-escalation and environmental changes have to go in continuously, synonymously as the medical assessment and the safety assessment. And you really use this trauma approach to care and the understanding that this behavior is really part of a medical problem. And it's not poor behavior, it's part of a trauma approach, and it's part of why the patient is acting in a manner that needs intervention.
All right, yeah, I want to dig a little bit deeper into the de-escalation techniques. I hear there's the ABCs of de-escalation. How do you approach de-escalation? What's a simple approach to de-escalating your agitated pediatric patient?
My favorite approach to de-escalation is actually the approach that's used by the 10 rules of verbal de-escalation, which is first, respect the patient, check myself out and don't get emotionally charged, and try to be as calm and overly calm as possible. Make sure there's a team approach and that there's a leader on the team. There's only one person communicating with the patient. And during that, give them space if it's possible. And sometimes patients are so agitated that that is not possible. But if at all, allow the patient to be a couple of hands from everybody. Don't be provocative. And even when the patient is provocative, don't do that. Have verbal contact one-on-one with the patient. Try to engage them in conversation. And this is true of even the severely agitated patient, so that you can give them choices like, we have to do this, but you have a choice to have an oral medicine versus an IM medicine, even if you're most likely going to go down a certain route. And be really concise and realistic. Don't try to offer things that are not going to happen. Like, you cannot leave this room. You cannot have your cell phone. That's often a cause of escalation. You can't talk to somebody. And really find out what they want, what their agenda is. I think this is no different than any other patient, even though the patient is very agitated. Like, what is your agenda? And I'm going to have to either meet your agenda or adjust your agenda. And then set the sort of limits of, I am going to need you to be safe. That's the most important issue right now, and the safety of our team. But it really does take a team. So I would say those are the initial steps regardless. If a patient is really unsafe, then you're having those discussions and you're thinking of this as a team, there is somebody anticipating medications. And I often offer oral medications, but we're planning for, do we need to give IM medications? What are we going to, based on this patient? Let's find out. Someone else on the team is finding out about what's the history of this patient, or getting collateral information from a family member or caretaker about how we can best approach this patient. But if I'm the one who's focusing on the patient, that's what I'm doing.
All right, great. And Dr. Chun, your approach to de-escalation, any tips or tricks or specific scripts or lines that you find useful?
Yeah, I would just add to what Sue said. I try to use simple, direct language, focusing on safety. Everyone needs to be safe here. So I want you to feel safe with us, and we need to feel safe with you. If they're doing something that makes us worried, I label it and be very direct. When you do this, when you say this, that makes us feel unsafe. How can we handle that? How can we all be safe? And try to engage them in that. Be clear, as Sue said, you have to be clear about what you can and can't do. It's really important to say it in a way that's, again, non-judgmental, non-threatening. Try to make it as collaborative as you can. That's why I favor words like, let's be safe. How can we be safe? When you do this, it makes us feel unsafe. How can we help you feel safe? And really try to engage in a dialogue.
Just to add, I don't think I emphasize this as much, and I think it's probably the most important thing, is to be kind and empathetic. These are often situations where agitated adolescents in particular are pushing, or kids in general, they're pushing your buttons. And then just step back. This child is traumatized, is mentally ill, is in crisis. And so really stepping back and saying, I've had the most luck engaging patients by just being nice to them and being empathetic.
Yeah, it's music to my ears because I've done several talks at conferences on compassionate care, and so it all fits in beautifully. All right, I want to go on to calling a code white. Calling a code white, that's, calling your security team if you have one. And this is a little bit controversial because calling a code white entails a lot of resource, and sometimes it can escalate things even further. I find that in general, code whites where I've worked in my career seem to be overcalled, and that I've seen so many times that patients escalate after having a code white called. On the flip side, there are some patients that absolutely require a code white to be called. And there's a way of doing a code white properly, and there's a way of doing it not properly. So, Dr. Chun, what are the indications for calling a code white in the pediatric population?
So calling a code white is about imminent risk of harm to the patient or to the staff. So to me, it's always a judgment call. When there is concern about that, that's when I would call a code white. When not to call a code white can be a little tricky because, as we know, agitation is a spectrum. And even being very verbally threatening and pacing, things like that, don't necessarily rise to that level. And I think if they're still talking to you, if you can still get them to engage with you, I would, as much as possible, try to avoid calling a code white and going through the steps that we talked about earlier and trying to prevent calling a code white.
In other words, it's, in our categories of mild, moderate to severe, this is just the severe patient is one of the indications, I would think, right?
Correct. Imminent risk of harm to themselves or to you or to the staff.
So I guess the pitfall there is to call a code white as a threat to an uncooperative patient, because I've seen that happen, and that usually just intensifies things. Dr. Duffy, any comments about your indication for when to call a code white and when not to call a code white?
I think it's when other avenues fail. So that means that managing an agitated patient takes time and takes some training, but it takes time. And so if a patient is agitated and they are disruptive and impending to hurt themselves or others, then the first step is really a de-escalation, is verbal de-escalation and identifying their wants and needs, thinking about changing their environment or adapting their environment. So that takes time. If those fail and the patient starts to escalate to the degree that they're harming themselves or others and are going to need additional intervention that maybe an oral medication might not alleviate, that they seem to be beyond the ability to make decisions and cooperate, then that's a reason to call a code white. But I think you were alluding to it, they are overcalled, but I think they would be overcalled when you don't have the right people in place to be constantly working with patients to de-escalate when they get agitated.
I'll focus on something you said, Anton, that to me, the biggest pitfall is what you said. And the operative or the key word is threat. It should never be a threat. It should never be used as you're threatening the patient with a code white. Because even there's gradations and gray areas. You may be very concerned. You may have your staff there and they can see them. That's not necessarily a bad thing. It's still how you present it to them. So the words I would use if I'm that worried, and I think it is that imminent, I'd say, I'm really worried about you. I feel really unsafe. Our team wants to keep you safe. We don't want to restrain you. How can we try to keep working with them? How can we keep them safe? How can we keep you safe? How can we not use physical restraints and keep trying to engage them? The point is that it's not a threat. It's not saying, if you don't do this, I'm calling all these people in to hold you down. And so it's really how you talk to them and how you present it to them. And it should never be a threat.
I was just thinking about the different levels of mental health and behavioral health codes. And from talking to colleagues around the country, a number of emergency departments have identified teams to respond at different levels. And if a patient is escalating and they need intense verbal de-escalation and maybe some mid-level intervention, one group of people are called. And then a code white, or a code, we call it code gray, would mean that would also involve a medical provider as well as security. And that is when it's really escalated to a point. So I do think as an emergency department team, it's important to think about, well, what are our different levels of response based on the patient's level of agitation?
All right, makes sense. I want to talk a little bit more about physical restraints. So let's say you have called a code white. Usually when you call a code white, it requires physical restraints. That's partly why you're calling the code white. And again, there's debate about physical restraints. If we do use them, how should we use them to avoid injuring our patient and the ED staff? Dr. Chun?
So, wow, a big topic, Anton. Physical restraint always should be as the last resort. Why? The Hartford Courant a couple decades ago published a very shocking expose on the dangers of physical restraint in mental health patients in both adults and kids. And there is a shockingly high mortality rate from it. That's what triggered a big interest in decreasing use of physical restraints. That's where the last resort comes from. So definitely some pitfalls. You want to avoid putting the patient in a prone position. That is a clear risk of injury to the patient. You want to avoid putting excessive pressure on the neck and chest and face, any airway issues. That may sound obvious, but in this type of situation, people may be trying to do anything they can to control the patient. You don't want to cover their face or mouth. Now, spitting and biting can be a challenge, but those are things that you want to avoid.
At our hospital, we've instituted a chair restraint methods, and it's been studied in pediatric inpatients in psychiatric settings. It's never been studied in the emergency department setting, but I find that even though restraint is not preferable, it is preferable to a prone or a supine restraint, in that the patient sitting up and they're in a chair, and it gives them a locus of control and a better way to communicate. And just anecdotally, patients spend a shorter period of time in restraint. So I think that that's something that's worth studying, the use of chair restraints in general. And they came from behavioral health, from developmental disability, children with developmental disabilities, and there are adult-sized chairs as well.
Interesting. That's something I've never heard of. It makes sense that the patient who's sitting will feel a little bit more in control. And yeah, it'd be great to see some studies to see if they're safe and if they do, as you've seen anecdotally, decrease the length of needing restraints. So just to review a few of the do's and don'ts of physical restraints. If you're going to use physical restraints, they need to be in the supine position. You should use 4 or 5 point restraints, not 2-point restraints, because they're associated with more injury. Make sure you use medical grade restraints. Restrain one arm above the head and the other one below the waist. Make sure you elevate the head of the bed to about 30 degrees. and make sure that the restraints are tied to the bed frame, not to the rails, because if they're tied to the rails, that can also lead to injury. And of course, you never want to have a pillow on the stretcher because that's a suffocation risk.
If I can make one comment, I would about the chair restraint. It's important that it's the right kind of chair. It's not any chair, because even restrained, depending on the type of chair, the patient can hurt and injure themselves. For example, head banging. And so it really does require the right kind of chair.
When you think of restraint, you automatically think of the leather and the physical restraint, but there's also holds and that's where I got into the training around restraint. Most security people learn what's called CPI, which includes restraining patients. And it's actually doesn't come from the healthcare profession, it comes from the law enforcement. But there are some medical training, particularly for children in restraint, and there's a method called safety care that many pediatric institutions, the staff are trained in safety care, which is a team de-escalation, but it's also various holds that keep the patient restrained and safe and feeling more secure. Obviously, it has to be adapted when the patient is large. There's also use of papooses, even large papooses, to protect the patient. This is sometimes beneficial to patients who have developmental disabilities. Just like the weighted blanket, it's a feeling of security that will help temporarily keep a patient safe and more secure. I think it's required that a patient who's in restraint be constantly observed. That's a very, very important issue. And the restraints have to be based on Joint Commission standards. There has to be an order. It's only for a limited period of time, so we have to adhere to that. But the constant observation and interaction with the patient, it would be very, very unusual in our setting for a patient to be restrained who does not at the same time receive medication. So it's part of the process that's very temporary, and really being in restraints for a shorter period of time is really the key.
That segues perfectly into a discussion about medications for the severely agitated patient. Just as you mentioned, ideally you want to be giving medications before or at least during the physical restraint if you're going that way. So let's talk about calming medications. First, how are you going to give the calming medication in a severely injured patient? Dr. Duffy?
Once again, just want to start by you're approaching the patient and always continuing to do verbal de-escalation, even when you're choosing medicines. You're always going to offer a patient oral medications, because I've been surprised over the years how severely agitated patients could all of a sudden say, "Don't give me an injection, I'll take an oral medicine." But most medications would be intramuscular. It's not safe to put an IV in a severely agitated patient, particularly for mental health reasons. It's not safe for the staff, and it's really not safe for the patient, even though IV medications work quickly. Also, many of the medicines we use are designed for intramuscular injection. It's important to establish what are the goals of why you're giving the medication. And I think we generally have goals to increase safety, but also to tailor the medication to what we know as the medical history of the patient, the psychiatric history, how they've responded to medicines in the past, what we believe is the etiology of agitation, because you really want to tailor the medicine to the patient and not go to one standard medicine, and what is your treatment? And it's really to calm the patient and not overly sedate. And then knowing the past response of patients to medications is really, really key, because we do not, and this becomes very, very important in patients with neurodevelopmental disabilities, to give them a medication that's just going to agitate them, or somebody with side effects to antipsychotics. Another important thing is to know your meds. Know what the onset of action is, when the peak effect is, and then have a plan of, until this medicine takes effect, what am I going to do? And that's where restraint often comes into effect. How are we going to manage the patient? Having unrealistic expectations that you're going to give an IM injection and all of a sudden the patient's going to be calm is just not the choice. And that's where a lot of the choices of medication have come in.
All right, so you touched on a lot of issues that we're going to get into a bit deeper, like which medications, depending on which etiology. But I want to start first with the undifferentiated, severely agitated patient who probably requires physical restraint. Let's say a 12-year-old, 90-pound child who's going ballistic, throwing objects, putting you and your staff at safety risk and not responding at all to your de-escalation attempts. What's your sort of go-to medication or combination of medications in the sort of undifferentiated, agitated patient who just comes wheeling in and you don't really have time for a thorough history, for example?
It's important to know that no patient is totally undifferentiated. So it's important to know your ABCs, and that's key. And you might not even have time to do vital signs, but it's important to do a physical assessment and recognize, is this most likely this, or is this most likely this? Get as much information as you can upfront from whoever's bringing them about past history, and that can help inform you as you choose a medication. And if I have a healthy person who has an underlying mental health disorder, who is undifferentiated, I would usually choose a second generation antipsychotic like Zyprexa in my setting. And that's because, unlike first generation antipsychotics, there's a lower risk of adverse side effects for this age patient, such as extrapyramidal symptoms. I can titrate the dose and start a lower dose. I know that I'm comfortable with the onset, which is going to be about 20 minutes or so, and it is generally effective in patients. An alternative that I might choose would be a first generation antipsychotic, which would be either droperidol or Haldol. Droperidol has, as you know, had a black box warning for a long time, but has been fairly well studied in inpatient pediatrics and in adults, and has a quicker onset of action of less than 15 minutes, and can also be combined with a benzodiazepine. Whereas a second generation, such as Zyprexa, it's not recommended that you include a benzodiazepine. So that's my go-to medicine. I want to couch that with Ativan is never a bad choice, but it often does in someone who potentially has a thought disorder or a developmental disorder. I find that it isn't always as effective. But I think Ativan for an undifferentiated choice, we had some discussion about midazolam, but I like Ativan because it has a longer duration of action, a longer half-life. And so with my goals are to keep a patient calm, I would choose Ativan.
So Zyprexa is olanzapine. So olanzapine is your go-to for the undifferentiated patient. We're going to talk about specific etiologies and what to choose based on that a little bit later in the podcast. Dr. Chun, your first choice medication in the undifferentiated patient, with the caveat that it's actually pretty rare to have a totally undifferentiated patient, that really we should be concentrating on finding the etiology, or at least getting some history. Is this a child living with autism? Is this a child with a known mental health illness? Is this an otherwise healthy kid? Is this a toxic ingestion? Usually we have some clue of what's causing the agitation. But in the rare event that it's completely undifferentiated, Dr. Chun, what's your go-to intramuscular medication for the severely agitated child?
Yeah, I agree with Sue that in that case where they're severely agitated, really don't have a lot of information, I usually do go with the combination of an antipsychotic and a benzodiazepine. In the old days, it used to be haloperidol and lorazepam. Nowadays, I would say more olanzapine and lorazepam.
So we have sort of a go-to olanzapine and lorazepam. And is that based on any specific evidence, or is that just based on your many years of experience?
Great question, because like so many things in pediatrics, there aren't great controlled studies for lots of reasons. The biggest one being that everything in pediatrics lags behind adult studies. There's lots and lots of adult studies on this topic. People are naturally more cautious with children, especially in terms of the long-term effects and the acute side effects. So no, there is not a great evidence-based answer. It's really a combination of experience and both between emergency medicine and also psychiatry, what they feel works best in kids. The other thing I was going to say about olanzapine, one really nice thing is that there's an orally dissolving tablet and it can be given intramuscularly. So that's one advantage, that it can be given different ways.
Most of the studies that have been done on inpatients and the experience from inpatients. There are some evolving pediatric emergency studies that have involved olanzapine. There's a recent systematic review that looked at droperidol, and there is also a fairly recent study that has looked at the use of droperidol in kids. So there are limited, it's really limited. It's mostly expert opinion. There are more and more studies are coming out from the pre-hospital setting, and the first randomized controlled trial that's due to start this year is actually going to compare droperidol and ketamine. So that would be another interesting study, and it's out of Australia. It's really hard to do a randomized controlled study of comparing medicine for agitation in kids in an emergency setting.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES. All right, so that's a little bit about the initial stabilization and management of the severely agitated child. Once we've given our medication and maybe employed restraints, our work is not really done. We then need to sort of manage the environment. As we've alluded to, the ED can be a highly distressing environment for the pediatric patient with intense lighting and loud noises, poor regulated temperature, unfamiliar objects, crowded and chaotic conditions, frequent interruptions from staff, and a lack of access to food and drinks. It's kind of no wonder that kids become agitated in the first place. So managing the patient in an appropriate setting is one of the most important steps after the initial stabilization. Dr. Duffy, what are some of the key moves to make when it comes to managing the environment around the agitated pediatric patient?
First is identifying an area that's the lowest stimulation area and still can assure safety in the emergency department. That is going to be the key factor in helping the patient decrease their agitation. But even if a patient's in a standard room in the ED, it would be, besides keeping the room free of as many things that could harm someone as possible, having low lighting, keeping the room quiet as possible, even allowing music, limiting the number of people who come in and out of the rooms. Think about it. I was in a room last night and the guy who emptied the trash walked in the middle of the room while I was like sewing a laceration, and the cleaning lady came in. I was like, why are all these people coming in here? So it's really limiting who comes in, giving the patient really personal space. I can't emphasize that enough. Like, read the vibes in the room. Don't sit too close. Don't get too close. Allow them to define their space. Offering food and drink, and using the people who came with them to go to Wendy's or something to get them what they might keep them calm. Things like puzzles and games, playing cards. We often use our constant observers. They bond with the kids and we'll play cards with them, or just engaging them. Of course, having iPads, videos, movies, any kind of distraction that's possible. Talking about things like practicing if you've got child life, they're very, very helpful. But I often talk to kids using guided imagery and talking to them about like, well, let's think about a place that you would like to be. What's your favorite place in the world? Who's your favorite person? Let's see if we can recreate this place for you. For kids with developmental disabilities, having weighted blankets, we have a whole autism closet. And I think that's worth every emergency department having an activities closet. And it makes the staff feel good to be able to offer, do you want to color? Do you want to draw? Would you like, one of those polling things that makes a lot of noise? And there are things like headphones and just personal comfort items that really make the difference. And food is a big one. So, a lot of emergency departments have crackers and limited number of juice. So, like expanding the array of food is very, very important.
All right, those are some great tips on managing the environment to help calm the patient. I want to talk about caregiver presence. That's also part of sort of managing the environment. Should the caregivers be present when you're managing the agitated child, or should you send them out of the room? If you do send them out of the room, how are you going to do that exactly? I mean, every situation is going to be different, but how do you decide whether the patient's parents or caregiver should be present or not?
Well, caregivers' presence is really standard in pediatrics. I mean, we are accustomed to having caregivers in the room when we're running codes, caregivers in the so just the presence of other people around to support kids is the standard. And I understand it isn't necessarily the standard for adults. Nobody comes alone, but sometimes caregivers can be the most disruptive and the triggers for agitation. And so that's important to identify that early. And if a caregiver is a trigger of agitation, or the patient says, I do not want this person in the room, then they should not be there, at least temporarily. And I approach it by just taking them out of the room, asking them to come out of the room and explaining to them that our goal right now is to keep their child safe and to be able to get as good a history, and that they are a critically important person of this process, because we expect that their child is most likely going to go home with them, which is usually happens, and we want them to be part of the process. So it's very rare that a parent will say, I won't leave. If a parent refuses to leave, then you have to work around that. It would be an unusual case where you would use your security to force a patient to leave. Usually it's bringing the patient in the room, the parent in the room, and discussing it with the child. But that would be a rare event. Sort of some pearls, as I was thinking about this question, to think about is if a parent does leave the room, ask them not to leave the premise, because they are an important part of the history, and you are going to want them to get history from them and collateral information. And there are a lot of parents who are agitated, and their child is disruptive and they need a break. And it's not unusual to have to search for parents, so they get the message it's okay to leave. It's also important, if a caregiver stays with a child, that they understand the sort of rules of the road and what the process is, just like the child. They understand that this is what's going to happen. You're going to have a physical exam. We're going to call the mental health team. It's maybe going to be hours, and setting realistic expectations, but also having a discussion with the parents and the caregiver that you don't want to bring in phones, and you don't want them to bring in, or if they're going to bring something in, to check with us first, that they don't want to do things that are going to agitate their child, and that this is a process. And then I find that it's really beneficial to interview the child and the caregiver together first, because it's really helpful to see the interaction between the two. I don't know if anybody's ever interviewed an adolescent by themselves. You hear this whole story and you think, I don't understand why you're here. Then you go talk to the parent on the phone and you're like, oh, now I understand why you're here. So if you can at all interview them together, and it's really sort of helpful to look at the dynamics of them. And then eventually you're going to talk to the patient alone. So caregivers are your most help. I mean, they are the families, but they can also be the most disruptive. So you have to sort of balance that.
All right. I mean, who knew there was so much to know about managing the caregiver of the agitated patient? All right. I want to get back to the medications. We had mentioned that calming medication decisions are ideally based on the etiology of the agitation. So, Dr. Chun, why is it important to sort out the etiology when it comes to choosing your first-line medication for agitation?
So understanding the etiology makes a big difference in what we choose because there are contraindications for certain medications depending on the etiology, as well as which ones work best. So, for example, with intoxication, usually benzodiazepine is going to be the most likely medication you'd choose. Whereas if you thought it was an adverse effect from a psychiatric medication, say neuroleptic malignant syndrome, you'd want to avoid giving neuroleptics or antipsychotics.
All right, great. So we'll get into the exact medication choices for the exact etiologies. You're alluding to the fact that we really need to consider a broad differential diagnosis in these kids, including organic causes like infection, neurologic causes, metabolic derangements, substance use, other poisons, environmental stress, pain, an escalation of an existing psychiatric disorder. So we need to do a thorough history and physical whenever we have the opportunity to do so to sort out the etiology, which will then guide our medication choices. So let's just talk a little bit about some key things you do on your history taking. I mean, this is, again, a wide differential diagnosis. But Dr. Duffy, when you have an agitated kid, what questions are you going to ask that'll really help you sort through your differential to help you guide your management and your calming medication choices?
I start with obviously the vital signs before, just like any other patient. Also, before I go in to take a history, we're lucky enough, as much as sometimes we hate the electronic medical record, we're lucky enough to have the electronic medical record. And so I scour it so that I can really focus my history and that I already get a lot of information about their past treatment, their psychiatric diagnoses, their past experience in our emergency department. So that's very, very helpful. If you don't have to walk in cold to this kind of exam, it's better to do it. As I mentioned, I try to interview the child and the parent together in order to do that. And then I also define when I'm talking to a patient alone that I define the limits of confidentiality. And I explain to them that I'm here to get as much information as possible so that I can help them and then get them along the steps of where they want to go next. But also that if they share anything with me that makes me concerned about their safety, then I'm going to be sharing that with others. I think the most important history that you're going to get from a patient, is the psychosocial history for mental health. And that's where the heads exam is a very, very important mnemonic and psychosocial history that actually serves as mental health assessment in adolescence as well. And for those who aren't familiar with the heads exam, it's looking at home environment. It's the life of a kid. And it gives you insight into what's going on with their medical and their psychosocial situation. So the mnemonic is home, education, employment, eating is the E, their activities. What do they do with friends? Are they future oriented? It gives you a good sight of what their sort of mind state is. You ask about drug use. We ask about sexual activity. It asks about sexuality. It's where you can also pull in a screen for suicide. So it gives you a good overall assessment of not only the mental health, but also the risk factors for ingestions, the risk factors for self-harm, the risk factors for community violence, the risk factors for medical illness, because it's all about the environment of the child.
Okay, fantastic. We'll have the head's exam mnemonic in the show notes for you. Let's talk a little bit about the physical exam. Dr. Duffy, you had mentioned that vital signs are vital. Beyond the vital signs, Dr. Chun, anything you're looking for particularly on the physical exam to help you sort through your differential diagnosis of the agitated pediatric patient?
Yeah, I'm looking for things that give me potential concern for a medical cause. In general, it's going to be things like a toxidrome, delirium, neurologic or mental status findings. So I would definitely focus those parts of the physical exam. We all know about toxidrome, so pupils, mucous membranes, vital signs, bowel sounds, skin, and temperature. And then the other things would be infection. So looking for signs of nuclear rigidity or rashes that makes us concerned about that. Also under skin, you might see cutting, injuries, or injection sites. All those things may point you towards an etiology.
Fantastic. So as we've mentioned, in order to choose the best calming medication, we ideally need to identify the etiology of the agitation. And we can think about the etiology by asking ourselves the following questions. First, is the patient developmentally delayed or autistic? Is there an underlying psychiatric disorder like anxiety disorder or depression, mania, or psychosis? Is this toxicological, intoxication, or withdrawal? Is this an acute confusional state brought on by an underlying medical problem like infection or metabolic or neurologic? Or we have no clue what the etiology is, which is probably rare by this point after you've done your history and physical, I hope. But before we get into the specific medications for the specific etiologies, there are some general principles we need to understand when it comes to medications for agitation. So, Dr. Chun, what are sort of the key principles that we need to understand about calming medications? And then we'll get into exactly which medications to use for which etiologies.
So in sort of rapid fire, if they're already on a medication and you think an additional dose may be helpful, that's usually a good place to start. And either an extra dose or a half of the usual dose may help. Ideally, you'd want to give oral medications rather than IM or IV. As Sue mentioned before, IM is much preferred over IV. If you are giving antipsychotics, you should be judicious and you need to monitor closely. The most common side effects are going to be extrapyramidal symptoms. The most serious, but fortunately rare, is cardiac arrhythmia. Depending on what the patient has, so for example, if you're really concerned about delirium, anticholinergic agents like diphenhydramine or benzodiazepines may actually make it worse, may disinhibit them. And if you've already given a medication, then I think you're in the category of, do you give a second dose of the same medication or do you use an adjunctive medication? That's sort of a judgment call, and it's going to depend on what you think the underlying etiology is.
All right, fantastic. So those are some good general principles. I'd now like to go through each of the etiologies and the best medication for each. So Dr. Duffy, first, for the developmentally delayed patient or the patient with autism spectrum disorder, what's your go-to calming medication and why?
Well, first of all, remember this is a special population of patients that something as simple as, or not simple as pain can cause agitation. So unlike other populations of patients, I always include, when I'm gonna give a medication, always giving ibuprofen or Tylenol at least, because that may be the key to what makes this patient better. As Tom mentioned, if a patient already has a whole medication and a PRN medication, which is often risperidone, then I would give them their PRN medication or a dose or a half dose of their standing medication orally first. This is a population that if you can avoid IM medication, it's probably better unless the patient is severely agitated. But I think that olanzapine would be, for a severely agitated patient, would be my first choice of go-to medicine because of the success in using the atypical antipsychotics in managing behavior in this population of patients. Sometimes, often, there are, as well as risperidone, quetiapine is also a common medication, so that would be another oral medication choice. I would avoid certain medications in developmentally challenged patients, particularly those with autism, anticholinergics and Ativan or benzodiazepines and antihistamines. Often there's a paradoxical reaction. So it's important to know if there's a history of that. Caretakers are really, really essential in sorting through which medications are going to be best for their child, but I'm wary of giving those for a patient. Sometimes for sedation, which is a different situation, but because there isn't a lot of research in kids, I mean, you always have to be thoughtful of what are the common things that we use in children that seem to work. And something like Precedex might be a choice for a patient, though it takes a long time. But if you're going to do a procedure and you anticipated agitation, and then we commonly use ketamine in children for sedation, including this population. But I think my go-to for agitation would be olanzapine.
All right. So for the developmentally delayed or child living with autism, you want to choose the medication that's worked best in the past, or an additional dose of their home medication. And then if that's not an option, then olanzapine seems to be your go-to.
I'll add the comment, Anton. This is true of all patients, but especially these patients. Ask the parents. They've been living with this their whole life, and they know very well. It's very likely they've seen this before, and they know what works best with their kids. So ask them what's worked, what doesn't work.
All right, so that's the child living with autism or the developmentally delayed child. Let's move on to the acute confusional state. Dr. Duffy, what about the patient with delirium or acute confusional state that you haven't sorted out yet? Or the patient, who has some sort of infectious or metabolic or neurologic cause? What is going to be your go-to calming medication for these patients?
In addition to trying to treat whatever is anticipating the cause and identifying that and not forgetting that we have to identify that, I would also choose second generation antipsychotic at a titrating dose. And I might choose a lower dose than I would for an acutely agitated patient that didn't have a delirium, because with the idea that this is a symptom of a different problem, I would avoid benzodiazepines typically or anticholinergics just because they may exacerbate the symptoms of delirium. So I think that's probably the route I would choose.
Okay, great. So again, it's going to be olanzapine, but this time probably at a lower dose than you might use otherwise, avoiding benzos and avoiding anticholinergics. Let's move on to the tox patient. In adult patients, I've been taught that benzodiazepines are the go-to calming medication for suspected undifferentiated tox patients because it's the safest. Dr. Chun, I think you had mentioned that benzos might be your go-to in the tox pediatric patient. Any comments about benzos for tox patients?
Absolutely. Benzodiazepines are my first line choice. The reasons are several. One is that it's the safest because you can reverse it if you're wrong. Two is if you are worried about antipsychotics, oftentimes the anticholinergic or the antidopaminergic effects can worsen the toxidrome. So that's another reason why a benzodiazepine would be my first line choice. And then in terms of which one to choose, there isn't a great evidence-based answer for that. I think it's really, again, what's your goal? Rapidity of onset and duration of onset. Midazolam might be a little faster, probably not a ton faster, but it'll also have the shortest duration of action. Historically, lorazepam or diazepam have been the most commonly used, but again, there isn't a great evidence base behind either. In general, I think it's because you want a slightly longer duration of action than what you get with midazolam.
Okay, so just summarizing the first line medication for agitation for each different etiology, it's going to be olanzapine for developmental delay and autism. It's going to be lower dose olanzapine for acute confusional state from a medical etiology, and benzos for the tox patient. I think that makes it pretty simple and is memorable. We will have a chart in the show notes going through all the specific options as well as all the dosages.
I think it's really important, though, to qualify that the medications are used in addition to ongoing de-escalation and environmental adjustments and adaptations, and sort of assessing the patient response. Just from years of experience, the medications are just one tool in your toolbox. It really is the other things in the long run that make the difference for the patient. And also anticipating most patients who present, to kids who present to the emergency department, no matter what their cause, have this pretty significant anxiety. And that's where, the discussion about Ativan versus midazolam comes in. And it's like, how do you alleviate, in addition to your thought disorder or whatever your other problems are, how do you help alleviate that anxiety while they're there?
All right. The one medication we haven't talked about yet in detail is ketamine. For the severely agitated, totally out of control adult patient, usually our first line go-to is ketamine 5 milligrams per kilogram IM. We're very familiar using ketamine for procedural sedation in kids and adults, and its safety profile is pretty good. Dr. Duffy, what do you think the role for ketamine is in the severely agitated pediatric patient?
Ketamine, you're right, is widely used in pediatrics for sedation of a whole variety of pediatric patients, but there is really limited to no research on its impact on the developing brain, and particularly those with mental health problems in its long-term effects. Even if in the short term, it may have sedating effects as a dissociative anesthetic, may do the job and work quickly. Our psychiatry colleagues, child and adolescent psychiatry colleagues, have a number of concerns about the use of ketamine because of the high rate of emergence as a child approaches adolescence. And that's why it's not used commonly in adults, because of the emergence reactions that occur. Also, because there's a belief that it exacerbates thought disorders and particularly psychosis. And no one in adults either, there aren't any long-term studies looking at what's the long-term impact of ketamine on somebody's psychiatric or emotional state. So I think for that reason, even though it may in the short run be a useful medicine, and I understand where it would be a go-to medicine. It keeps vital signs relatively stable, although I would say in the adult literature, the pre-hospital literature, there appears to be a higher rate of respiratory failure and need for intubation. It requires close monitoring. The doses, an IM dose of ketamine, we almost always give ketamine IV in our emergency setting and in most pediatric emergency settings, because you can titrate it to the patient, and there's variable response in IM ketamine, and the effects are less longer. Although in the pre-hospitalization, there might be some rationale to a large, undifferentiated, disruptive, unsafe patient, I think in a controlled setting, there are other choices that don't have the concerns about what its long-term impact on the developing brain is. So that for that reason, I don't use ketamine for agitation.
Very interesting. I do encourage any listeners to email me or post in the comments on the blog post for this episode if they have any alternative views on ketamine. That's a really interesting one. In adult emergency medicine, we love ketamine. We use it all the time. And so I think that's a really interesting perspective. Dr. Chun, do you ever reach for ketamine in the agitated pediatric patient?
I would echo what Sue said. I think the issue is we just don't have a good evidence base. As she mentioned, our child psychiatry colleagues have very strong feelings against it because they have concerns about it possibly worsening symptoms, and they'll cite you cases of that. I think the problem is we just don't have a good evidence base, and hopefully that will change soon.
Okay, great. Yeah. I mean, ketamine's being used in adult patients for suicidality. It's been under study. I look forward to some more study on ketamine in kids and the long-term effects. The other medication that I sometimes see used for mild to moderate pediatric agitation is diphenhydramine. And this is another one that we use all the time in the emergency department. Dr. Chun, what's your take on using diphenhydramine for mild to moderate pediatric agitation?
Well, to be a broken record, there's not a big, strong evidence base for it. You're 100%. It is used very commonly in inpatient psychiatric settings. They like it only for mild and moderate, mostly because of comfort using it, easy access to it. So people are very comfortable prescribing it. Not going to do a whole lot for a patient who's severely agitated. A very important thing to remember is that you want to avoid it if you're concerned about delirium, as there's a good chance the anticholinergic part of diphenhydramine will make the delirium worse.
Interestingly, when we developed the TREC guidelines, this was a collaboration with our Canadian colleagues. Benadryl in general is not used in Canada. And it stems not only from pediatrics, but from the geriatric population, where there's an evolving body of evidence that Benadryl, exacerbates cognitive function, and the long-term effects may be deleterious to patients. It's often used in young children because there's this relative comfort of giving Benadryl, and so this is just Benadryl but it also is another drug that's famous for causing paradoxical reactions in young children as well as those with developmental disabilities.
All right. So certainly not your go-to medication. If you use diphenhydramine a lot for agitation in pediatrics, you may want to consider some alternatives. So once we've stabilized our patient, we've sorted out the etiology, we have to decide whether we need to get psychiatry involved or not. Dr. Duffy, when would you suggest we pick up the phone to our on-call psychiatrist in the management of these agitated pediatric patients?
I tend to call psychiatrists when I have a specific question. I find that they're the most helpful when there is a specific question. So it's like differentiating complex symptoms and how do I tailor the treatment for this patient while they're with me for these complex symptoms. If I need help in performing a mental status exam with a developmentally disabled patient or somebody who's potentially got catatonia, and I'm not really sure what's going on, and I want help figuring that out and assessing the patient's capacity. If I want help developing some kind of treatment or management plan, at least in the short term, and also if you're mixing medicines, they're very helpful in knowing the complementary effects of medicines, the adverse effects, what you would put together, like, why don't you add this? This might help. And then also helping to determine the appropriate level of care and disposition for the patient. Sometimes they have insight into what are the resources available. So that's the main reason I would call them.
All right, great. I want to talk a little bit about how to implement change in our EDs so that we can manage these pediatric agitation patients in the best possible way. We had talked at the top of the podcast a bit about protocols and guides. Dr. Chun, how can we best implement change in our EDs to take great care of these patients?
So by far, my biggest suggestion is to take a look at the agitation care pathways that are out there. There are a number of excellent ones out there. They're readily available on the web, and we'll provide you with the links to them. They help give you an approach, a plan for everyone of how to approach these patients. It helps give you tips on how to personalize a de-escalation plan for a patient. It also helps you and your group develop a standard medication order set, list, steps and procedures and processes of which medications and when. I'll add, Anton, thanks for bringing this really important issue up. I know these kids are challenging and uncomfortable to care for everyone, including me. There's a lot of resources out there, and I hope that that's one of the big takeaways from today is there's a lot of resources out there to help with the care of these patients, which we'll provide the links to.
All right. Any last words of wisdom in terms of how we manage pediatric patients who are agitated in the emergency department Any pharmacologic pearls? Any other pearls that you can share with us, Dr. Duffy?
I think the importance is recognizing that it takes a team to put together a team that can respond, because it's definitely a series of skills that help mitigate agitation in kids. It's also putting processes, as Tom mentioned, in place to start from the minute the patient walks in the door, to create an environment and a setting to alleviate agitation, and then to manage it and make sure patient goes the place where they're the safest. Also, to have a trauma-informed approach, that understanding that these behaviors are a manifestation of an illness, of a situation, and to be kind and patient-centered, and recognize that the patient comes with others who are they're most likely gonna go home. So I think those are the words of advice I give.
Fantastic. And Dr. Chun, any last words of wisdom?
Treat them like you would any other medical patient. So being present makes a huge, huge difference. History and physical exam, same thing, make a huge, huge difference. And I think something that I ask all medical patients, but especially these patients, what works, what doesn't work. A lot of times the parent have really good ideas, and ask the question and listen to what they say.
All right. Well, thanks so much to both of you for your keen insights into the management of the pediatric agitated patient. I hope our listeners will use this knowledge to advocate for change in their EDs with clinical pathways, maybe standardized order sets and de-escalation plans, so that we can turn our agitated patients, agitated emergency physicians, and the chaotic ED environment that they can cause into calm patients, calm emergency physicians, calm teams, and better outcomes for our kids. So thank you very much.
Thanks, Anton, for having us today. The patients with the mental and behavioral health issues, they come to emergency departments. There are patients, just like every other patient and family who's in crisis. They look for our care, and having preparation and doing best practices and using our expertise is really going to be what's going to help them in the long run. So really, thanks for the attention to this today.